Hi, my name is Emily Pazmiño. This is Medical English, and today I'm going to talk about systemic therapy for metastatic renal cell carcinoma. Definition. Kidney cancer occurs when healthy cells in one or both kidneys change and grow out of control, forming a mass called a renal cortical tumor, which can be malignant, indolent, or benign. The malignant tumor is cancerous, which means it can grow and spread to other parts of the body. An indolent tumor is also cancerous, but this type of tumor rarely spreads to other parts of the body. A benign tumor means that the tumor may grow but will not spread.
Renal cell carcinoma is the most common type of kidney cancer in adults. It accounts for approximately 3% of adult cancers, and the incidence has risen steadily by about 2 to 4% each year in the past few decades. It is effectively a collection of different types of tumors, each derived from the various parts of the kidney cell and displaying salient genetic characteristics, histological features, and, to some extent, clinical picture. When it metastasizes, it has the tendency to spread to the lymph nodes, lungs, liver, adrenal glands, brain, or bones. While the exact cause of renal cell carcinoma is unknown, there are risk factors that increase the chance of developing it, such as smoking, high blood pressure, family history of kidney cancer, and obesity. The chance of developing renal cell carcinoma increases with the age, and males have double the chance of having it compared to females. In a lot of patients, this cancer may not produce any symptoms for most of its course. Only about 10% of patients present with the classic triad of flank pain, blood in the urine, and lump in the abdomen. Other signs and symptoms may include unexplained weight loss, fever, night sweats, weakness, fatigue, nausea, and high blood pressure. Renal cell carcinoma is associated with a number of paraneoplastic syndromes, which are conditions caused by either the tumor hormones produced by the tumor or by the body's attack on the tumor. In about 20% of these patients, paraneoplastic syndromes are present, such as high blood calcium levels, high red blood cell count, high platelet count, and deposition of amyloid protein in one or more organ systems. To diagnose renal cell carcinoma, signs and symptoms and past medical history play significant roles. Based on the symptoms and signs, a range of biochemical tests are considered to provide sufficient diagnostic clues. Kidney imaging is vital, mainly consisting of ultrasound, CT scanning, and MRI scanning of the kidneys. Biopsy of the suspected kidney mass helps confirmation of the diagnosis. To evaluate the extent of cancer spread, PET scanning is the standard imaging modality. The therapeutic approach to renal cell carcinoma is guided by the stage or degree of tumor spread, pre-existing medical conditions, and overall health and age of the person. The principal treatment options for renal cell carcinoma consist of surgery, immunotherapy, and targeted therapy. Partial or complete removal of the affected kidney is the standard treatment for localized renal cell carcinoma. Immunotherapy, or biologic therapy, works by boosting the body's immune system to help destroy cancer cells. Cytokines are the artificially engineered versions of natural proteins that activate the immune system, and the ones most often to treat kidney cancer are interleukin-2 and interferon alpha. The targeted therapy works by blocking growth of the new blood vessels that nourish cancer cells or downplaying important proteins in cancer cells that help them grow, or both. Clinical response rates with chemotherapy, either monoagent or combination, are usually less than 15%. Renal cell carcinoma is not very sensitive to radiation, and radiation therapy is more often used to palliate or ease cancer symptoms in case of cancer spread.
Applications in medicine. Currently, the most effective treatment for metastatic kidney cancer is immunotherapy, combinations that activate the immune system to attack cancer cells. These drugs have been shown to extend life compared to standard treatment. Palliative care is also important to help relieve symptoms and side effects.
In localized kidney cancer, the treatment is still absolutely surgical. We still don't have a clear steer on whether or not there is going to be any benefit to adjuvant treatments in kidney cancer. We're getting some signals from some of the trials, like the S-TRACK study results that have recently coming out and showing us that there is a possible advantage in terms of progression-free survival to having sunitinib therapy. But that hasn't been mirrored across the board with a couple of the other studies that have reported. So we await a little bit more information there. Certainly isn't standard of care at the moment. So still in localized disease, the standard treatment is to undertake surgery. In terms of metastatic disease, the landscape is changing somewhat. Still, first-line metastatic disease is treated largely with systemic therapy, with tyrosine kinase inhibitors still being the standard of care. But interestingly, we're now getting a large number of options in second-line treatment of metastatic kidney cancer. And most excitingly are the immuno-oncology drugs, the T-cell checkpoint inhibitors that are coming through, and now there is a place for their use in second-line therapy.
Pros and cons. Pros. Renal cell cancer can be cured if it is diagnosed and treated while it is still localized in the kidney and immediate surrounding tissue. Surgery allows the removal of a large volume of the tumor, which can instantly reduce symptoms. For the cons, the surgery may present failure to kill microscopic disease around the edge of the tumor, leaving tumor cells in the patient after surgery. The patient may suffer some damage to nearly normal tissues during surgery, removal of ribs or normal lung tissue to reach a lung tumor.
Regarding my thoughts on the recent advancement in the treatment of metastatic renal cell carcinoma, I would say that there has been a lot of exciting, substantial progress in the treatment of this disease. You know, for many, many years, throughout the 90s and until even 2005, there was only one therapy approved for this disease. And now, in the past few years, there have been more than 10 different regimens FDA approved for the treatment of this cancer. So this is good news for our patients. At the same time, we still need to do better. So we have quite a good number of patients that respond, but we have others that do not respond, and we need to determine what regimens we can use to help those patients. And of course, the ultimate goal is to, if possible, make them disease-free, remove all of their cancer from their bodies. So these are the next steps. In addition, while there have been quite a few advancements for the treatment of clear cell renal cell carcinoma, which is the most common type of kidney cancer, there are many other subtypes for which those treatments that have been FDA approved do not work in the same manner. So there is still a lot of research that needs to happen, both to understand more how we can leverage those therapies for these more rare subtypes, and also to develop new therapies that are directly developed for these cancers.
Issue applied in Ecuador. The theme of choice for systemic therapy in Ecuador in patients with metastatic renal cancer is mainly related to sunitinib. In 83% of the cases, and in the rest of the cases, they mention that it is variable, since it depends on the prognosis, or they propose bevacizumab interferon. Conclusion: renal cancer constitutes 2 or 3% of all malignant pathologies, of which clear cell renal carcinoma accounts for approximately 85%. Since this histopathological type is resistant to chemotherapy, new treatments, molecularly called target therapy, are used worldwide with significant results in terms of progression-free survival and overall survival. Thank you.